قولي أمتى نبدأ؟
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody. Good morning, good evening, good afternoon, wherever you are. You are most welcome to this session of Glaucoma Club, Glaucoma series in Sinjab Academy Club. And today I would like to welcome again Dr. Gdih and Dr. Munir. Dr. Gdih will talk today about glaucoma surgery complication management. Dr. Gdih, the stage is yours. Thank you very much.
Thank you, Dr. Sinjab. Welcome, everyone. We're going to be talking about, these are my disclosures. I have nothing related in this lecture that I have a conflict of interest. I would like to acknowledge Dr. Karim Damji and Dr. Bernard Hurley for using some of their slides in this lecture. What are we going to do within this next hour? We're going to try to learn the essential principles that need to be kept in mind during glaucoma filtration surgery. We try to recognize and manage intra-op, early post-op, and late post-op complications associated with glaucoma filtration procedure. Prevention of complications, what steps we should take to prevent complications. And then the focus in this lecture will be on trabeculectomy surgery, but these all are applicable to almost all glaucoma filtration surgery. So you can use it anywhere, whether you're using a MIGS or a tube or a trab, it's all applicable. Anyone know why I put this picture on? Well, if you notice, it has all the weapons, like from very old age until the recent age, and it has all types of weapons, whether it's light or heavy. So if you decided to do glaucoma surgery, keep everything on the table and have every weapon possible to be used whenever needed. So so just that you don't get lost in all these complication managements, I'll just give you an outline how I'm going to run this lecture. So the complications will be divided into pre and intra-op and post-op. We'll start with the pre-op intraoperative complications. Before we start the surgery, even you can have retrobulbar hemorrhage for those who are using blocks. You can have a conjunctival buttonhole when you start with your dissection of the conjunctiva. You can have a flap disinsertion or tear even before you open the trabecular meshwork. And you can have a vitreous loss in between, and you can have intraoperative bleeding, whether it's coming from the iris or ciliary body or the choroid. So strategies at the start up, what should you do before you start? You should have things like adequate anesthesia. If you have a patient that's wiggling on the table and not comfortable during the procedure, they may move sudden movement or do something that can cause a complication. So these are things outside your skills that you can ensure that they have adequate anesthesia, so they will be comfortable throughout the procedure. Also, a good exposure is a good thing, because if you try to dissect in a very tight angle or try to do something that's non-visible or cutting blindly, all these can result in a complication that you don't want to see. So in glaucoma surgery, we start with a bridle suture, and the bridle is the rope that's wrapped around the horse for a better control. So it's the same thing here when you insert the suture in the peripheral cornea and then expose the superior conjunctiva for a better dissection and control. So how to avoid conjunctival buttonhole? Grasp tenons rather than conjunctiva and use a non-toothed forceps. Avoid exposing edge of conjunctiva to anti-metabolites. Blunt dissection when possible. Use a blunt Westcott scissor, because we have a blunt and we have a sharp Westcott. Use the blunt one. And whenever you can, keep the Westcott scissor closed and then just keep on dissecting bluntly, and then cut when needed. Always visualize conjunctiva during sharp dissection. When you're cutting something, always have a visibility. Never cut blindly. Close defects with fine sutures. Let's say you're dissecting a very fine conjunctiva, especially those patients with who are on eye drops for a very long time. They will have a very fine conjunctiva that if you may inadvertently cut their conjunctiva. If it happens during the procedure, you may want to close it with a very fine suture, like a 9/0 vicryl with a non-cutting taper point or the blood vessel needle. Avoid anterior ciliary arteries near muscles. Try not to get close to them. Use gentle bipolar cautery when needed. Avoid bleeding from ciliary body. May need to dissect and enter more anteriorly than planned. So this is when you create your flap. When you look at when you're trying to do the trabeculectomy part of the surgery, you may want to cut more anterior to avoid cutting ciliary body and bleeding after that. How to prevent hypotony? Hypotony, make sure you have a thick, firmly closed scleral flap. It's always better to close tightly and then loosen as needed, in the early post-op stage. Test flow after closure of sclera and before closing conjunctiva. Make sure that either there is a very minimal flow or just oozing. If you see like active flow during that, before you close conjunctiva, make sure to go back and enhance more sutures on the sclera flap. Meticulous closure of conjunctiva is a key in glaucoma surgery, because the worst thing you can have the day after surgery is having a flat AC. It's always okay to have a higher pressure, because that's can be dealt with easier than having a flat AC and a low pressure. After conjunctival closure, apply 2% of fluorescein minims and look for leaks. If there are any leaks, you better close them while the patient on the table before you conclude the surgery. If after BSS injection into the AC, if the AC is still shallow significantly, consider injecting Helon GV into the AC and leave it there. Leave a side port temporarily for post-op hypotony management. Always at the end of your case, if you haven't done that from the beginning, make a corneal side port temporarily with a 15-degree blade. you have access to the AC in the post-operative stage. If you get a retrobulbar hemorrhage before you start, many people use a retrobulbar block, before glaucoma procedure. I personally don't do blocks, but if any, some people are comfortable using blocks. If you do and you get retrobulbar hemorrhage, this is an urgent action required. So if the eyeball starts to extrude out of the orbit, then you may need to abort the procedure and deal with things that's happening. You can only proceed if the hemorrhage is limited and the intraocular pressure is not elevated. If the ocular contents are protruding and then you have to deal with this complication, then always check visual acuity, intraocular pressure, status of the central retinal artery. You might have to start IV mannitol, IV Diamox, or even IV steroid. And then lateral canthotomy and cantholysis if the orbit is, if the optic nerve is at risk and that you're going to lose the globe, you might have to do orbital decompression or even infracture medial wall or inferior wall. So as we said for the conjunctival buttonhole, we are going to prevent that by using a non-toothed forceps, a broad-based grip, meaning when you hold conjunctiva, make sure you hold it not from the edge, but away from the edge, and a broad-based grip. If the buttonhole happens early in surgery, consider changing the site of surgery, especially if you have enough real estate. Let's say you start here, and then you got a conjunctival buttonhole. You can let this go and then start another one on the other quadrant. If it happens later in surgery, then horizontal mattress suture using either 10-0 nylon or 9-0 Vicryl on a vascular needle and closing that buttonhole is very essential. Flap disinsertion or tear. What if you disinsert or cut the flap while creating it? Then first attempt replacement. Suture with 10-0 nylon. If that's impossible, then a scleral patch graft is possible, or even a different location. Just move on to another quadrant and close this off. If you get a flap hole, suture if possible, patch with Tenon's capsule or Helon GV in AC if appropriate. Manage as a full thickness fistula. Expect hypotony for some time post-op if that happens. Vitreous loss. Sometimes while you're creating your, when you finish the trabeculectomy part of the surgery, you see a vitreous loss. If you see this could be an early sign of suprachoroidal hemorrhage. So be attentive to that and always use your Wexel to wipe and see if there is any vitreous, because that could indicate a pressure from behind, especially in those who are pseudophakic. And then also, if you see vitreous coming, that's also a risk of malignant glaucoma post-operative. You couldn't, because it can happen after trabeculectomy surgery. So this is a picture just for everyone to look at for a few seconds. So we see an eye with an anterior chamber IOL. We see a broad iridectomy here. And then what you notice here in the pupil, like we don't see a red reflex. We see tissue behind. So what comes to mind? Let's see in the comments. Anyway, here's a question. So this was a suprachoroidal hemorrhage for those who could identify it. First thing you do is you lose red reflex while operating, and you see that tissue, you see that retina coming right to the pupil side. Okay, so read this question. I'll give you seconds, and then everyone can post their answer on the comments there. Important intraoperative signs of suprachoroidal hemorrhage include all of the following except: A, darkening of red reflex; B, vitreous emerging from the wound; firm eye on palpation; subconjunctival hemorrhage; intraoperative tachycardia more than 85 per minute. I'm sorry. Yeah, Tara, you answered correctly. Yeah, so it's B. Sorry, it's D. Yeah, so many answers. Yeah, that's right. So the least important in here is the subconjunctival hemorrhage. You can have subconjunctival hemorrhage even from touching the conjunctiva with your forceps. So this is the least important among all these points.
Dr. Gdih, tachycardia is associated or brachycardia? What do you think?
Tachycardia. It's basically when the hemorrhage happens. I think the body defense mechanism is that it will increase the heart rate. You know, whenever you have bleeding, you will increase the heart rate.
Yes.
Yeah.
Interesting. Yeah.
Yeah. But
Thank you.
Yeah, you're welcome. And don't forget the surgeon's tachycardia too.
The most important.
Most important. When this happens.
Sometimes collapse.
Exactly. Prevention of suprachoroidal hemorrhage. How we prevent that? You may consider cyclophotocoagulation instead of filtration procedure for some patients. If patients is on anticoagulation, can this be safely discontinued pre-op? You can ask their family doctor or their internist or cardiologist to put them on that to see if you can safely stop it for a week or so pre and post-op. What are the risk factors for suprachoroidal hemorrhage? Ocular hypotony for a long time in a prolonged procedure where you have and I guess Dr. Mazen, you see that in cornea transplant where you have the open sky eye, when you have that open globe for a long time, it's a risk for suprachoroidal hemorrhage.
Yes.
Advanced age, people with atherosclerosis, arteriosclerosis, hypertension, aphakia or myopia, nanophthalmic eyes, and also elevated episcleral venous pressure like Sturge-Weber syndrome, people on anticoagulants, high pre-op intraocular pressure, especially when you start with a pressure more than 40 for a filtration procedure. You may want to give IV mannitol before you start, just that you don't jump from a very high pressure to a very low pressure where you can have an event of ruptured choroidal blood vessels. Also choroidal hemangiomas, as I mentioned, Sturge-Weber syndrome. For the choroidal, suprachoroidal hemorrhage, you can have a peripheral non-significant ones, or you can have what we call kissing choroidals, which is an emergency that need to be dealt with. Signs of that: sudden increase in intraocular pressure. So you'll be operating and all of a sudden the pressure rises and you feel like the globe is hard. Flattening of the AC. Forward movement of intraocular contents, including the iris, sometimes the retina, sometimes the choroid will be all expelled out. How to avoid large intraocular pressure drop intra-op. So using intra-op mannitol is a good idea. Excessive tissue distortion, Also, try to avoid that. Prolonged hypotony, intra and post-op. Whenever you have hypotony, even if everything looks good, try not to keep the patient hypotenuse for a long time. That's why you have a side port after. Remember, we said leave a side port on the temporal cornea, so that if you have hypotony post-op and you have overfiltering BLEB or whatever, then you may want to fill the AC with some Helon and keep some pressure in the eye to avoid that disaster from happening. Treatment, if it happens intra-op, close the eye as soon as possible. You may consider pre-placing flap sutures before you start, opening the AC. It gives you a faster closure. Consider scleral drainage 3 to 4 millimeter posterior to the limbus if you are dealing with it intraoperative. Also, one of the risks or one of the reasons why a patient can have intraoperative bleeding is when iris root or ciliary body has been damaged while you're cutting while you're doing your peripheral iridectomy, surgical iridectomy. While you're one of the steps of trabeculectomy is peripheral surgical iridectomy. Sometimes a surgeon will cut too posterior, and they can inadvertently cut the ciliary body or iris root, and it's highly vascular, and then you can have bleeding. How to manage? Use cold BSS to use a wet field cautery. Also tamponade with Wexels or viscoelastic material. Tight closure with extra sutures, and preferably if it would be a removable suture. Then also intra-op, you can have hyphema, either severe. If it is severe, you gotta wash it out before you conclude the surgery. Or if it is minimal to moderate, then you can either do a minimal irrigation or may leave it even. That's okay to leave a grade 1 hyphema at the end of procedure. Post-operative complications, we divide them into early and late, as I said. In early, we're going to talk about any intraocular pressure, low intraocular pressure or high intraocular pressure. And late, we're going to talk about the same thing, whether we have a late with any intraocular pressure, or a late complication with low intraocular pressure, or a late complication with a high intraocular pressure. Let's take the early one. So you have an early complication with any intraocular pressure. What could these be? You can have hyphema, you can have uveitis, or you can have Dellin. Hyphema, usual management as you would manage any hyphema. Wait it out, identify the bleeding vessel. You can use argon laser if you can see the blood vessel that's bleeding. If it is severe, you may need to wash out, especially if the pressure is more than 25. Uveitis, treat aggressively with steroid and atropine or cycloplegics. If it is a Dellin, you can use lubrication and wait it out, and it usually clears. Now, early and low intraocular pressure. What can we have early complication with low intraocular pressure? We can divide them into formed BLEB and flat BLEB. Here's a question before we move into that. A 63-year-old white female, 3 days post-trab, early hypotony secondary to overfiltration with peripheral iris iridocorneal touch and central AC, 2 cornea thicknesses. What's the best management option? Injection of Helon GV intracamerally, sorry. Switch antibiotic to gentamicin and reduce steroid, or follow up in few days no change in treatment, apply oversized contact lens, or drain the choroidals and reform AC. There is no right or wrong. It just, you think among the options that you have. Okay, it's good. We have answers all across the board.
Yeah, mashallah, there is a very good interaction from the audience.
Yeah, just I mean, I wouldn't make anyone faulty for injecting Helon Gdih intracamerally. I mean, you could do that. It depends on how comfortable you are with the situation. But in my case, I would probably follow up in a few days and no change in treatment, because it is only 3 days. And I mean, the AC is still formed. You have two cornea thicknesses. So you can argue that, but a close follow-up is important. So I would go with C. Okay, so back to the early post-op complication with low intraocular pressure with formed BLEB. Okay, so we have low pressure but formed BLEB. What does that mean? It means either overfiltration. Okay, before I continue, I want everyone to look at the complication from the dynamics of the aqueous humor. Okay, so think about the aqueous humor. Where is the aqueous humor? So if you think about it, if it is in the BLEB, you're going to have a high BLEB, low pressure, and shallow AC. Just think about it. All the aqueous ended up in the flap under the BLEB. So overfiltration. What to do for overfiltration? Usually a loose flap. You can have you can add a suture to the flap, even across the conjunctiva. You can put a suture to tighten the flap. Management for overfiltering BLEB: put them on cycloplegics, decrease the steroid, with or without aqueous suppressants, because you want to have less aqueous going through. You can add gentamicin. Gentamicin will evoke inflammation, so that will increase more fibroblasts activity, and then maybe scar down the surgery a bit. Torpedo pressure patch on the above the flap is not a bad idea. And torpedo patch, by the way, is where you take a small patch and you wrap it around and make some pressure points and direct it way just over the flow area and put a tight pressure on it. Or oversized the scleral contact lens is also it can be used. If it is prolonged, reform chamber by Helon Gdih or surgical revision. Okay, now we're down to flat BLEB. What if we have low intraocular pressure but flat BLEB? You can think about it. Where did the aqueous go? If it is not in the anterior chamber and not in the flap, not under the BLEB. So where did the aqueous go? We're losing it. It's going outside. So that means you have a wound leak. So wound leak, or it's probably buttonhole, you can either patch or use a large diameter scleral contact lens or surgical repair, or gentamicin drops as well. You can evoke inflammation by using that. Okay, now early low intraocular pressure also can be choroidal effusion. Setting of hypotony. you have a hypotony. Chamber can be deep or shallow, can be either way. Choroidals themselves contribute to hypotony, will resolve when increased intraocular pressure. Sometimes it's like the chicken and the egg. No one knows which one comes first. You know, is it the ciliary body inflammation caused hypotony, or is the hypotony caused choroidal effusion? There's always you know, a discussion about which one comes first, but it is definitely an inflammatory process, and a steroid is helpful in this condition. And then you have early post-op complication with high IOP. If we have high IOP, choroidal effusion can be there as well. So must address underlying cause. If it is wound leak, you address it. If it is a loose flap, you address it. Heal-on GV in AC initially can be used, or surgical drainage also can be done. Here is a just a diagram of the different shallowing of the AC. So stage number 1 is when you have a shallow only peripheral iridocorneal touch, and then stage 2 where you have peripheral and mid-peripheral iridocorneal touch, and then stage 3 where you have complete iridocorneal touch, except the AC is formed centrally, but there is no lenticular corneal touch. And stage number 4 where you have lenticulo-corneal touch. This one is the most serious, where you have to intervene. And for some reason, the human natural lens is very toxic to the endothelium. Therefore, you can have endothelial dysfunction very quickly if you don't get this resolved. I don't know, for some reason, Dr. Mazen, do you know why the human corneal lens is more toxic than the artificial lens, for example? Any explanation of that?
I think the artificial lens is made of something inert that doesn't have reaction, while the crystalline lens, the human crystalline lens, is organic. So, you know, it is full of proteins, full of, yeah,
that makes sense. Thank you.
Mm-hmm.
Okay, then now we're early stage, but high intraocular pressure. High intraocular pressure where the choroidals come in touch and then everything rises. We call it kissing choroidals. Urgent drainage is you know, you can argue about it, but it's mentioned in the books that you have to do an urgent drainage. But what I have seen over the years that even with the kissing choroidals, our retina colleagues have a different idea about it, and they like to treat it medically first before they go in. They believe that 50% of them resolve without having to do surgical intervention. Theoretically, adhesions can happen from 24 to 48 hours when they touch like that. May disrupt small optic nerve head vessels, so you can have ischemic optic neuropathy. May cause central flattening of chamber, lens, or corneal damage. Okay, so again, with low intraocular pressure, you can have, it can be due to ciliary body shutdown, or it can be also due to cyclodialysis cleft. Excessive inflammation can cause ciliary body shutdown, so treat with steroid and cycloplegia. Avoid beta blockers and carbonic anhydrase inhibitors because they can worsen the condition. Cyclodialysis cleft is something that many people don't think about, but if you have a low pressure early post-op and you don't see other reason, if you do a UBM, you may see a cleft there, and that's where the fluid is going to the suprachoroidal space. And those are very hard to diagnose unless you exclude everything else or have a UBM ready to have an image like this. And you may not always capture this nice of image. So you can try to identify with gonio, but it's hard, or UBM. If that's the case, use atropine, decrease steroid. You can try argon laser with Goldman lens to treat, but definite surgery, definite treatment is surgical repair. Okay, early but high IOP. Okay, as I said, always think about the aqueous. Where is the aqueous? Where is the problem? Okay, if you follow the aqueous, you can know where the problem is. Okay, now you have a high intraocular pressure, but deep anterior chamber. So what does that mean? Think about it. The aqueous have nowhere to go. That means we have a blockage somewhere. So our filtration surgery is not working. Or you can have high intraocular pressure, but flat anterior chamber or shallow, very shallow. How come? So where is the aqueous now?
In the vitreous, malignant glaucoma.
Exactly. Exactly. So if we follow the aqueous, we will always know what's going on. Let me see the answers here. Okay. Okay, good. I like the interaction. Yeah, someone asked, what does it mean by two cornea thicknesses? It just means if you look at the cornea as a thickness, two measurements of the cornea in that anterior chamber.
You mean we use the slit lamp and then we see the thickness of the slit itself in the cornea.
Exactly.
Yeah. Accordingly, we can compare the thickness of the cornea with the depth of the anterior chamber.
Exactly.
Mm-hmm.
Okay, so deep anterior chamber or flat anterior chamber?
Now, Dr. Gdih,
yes.
I think you used a tricky answer in one of the questions that we switched into gentamicin. So somebody is asking, why gentamicin itself? Does it have?
Oh yeah, sorry about that. I should have explained it. Yes, gentamicin by nature is very irritant. If you talk to your patient and ask them why you just stopped using gentamicin, they will say it's very irritating. It's one of the antibiotics that cause irritation and inflammation in the eye. So using the nature of the inflammatory reaction that gentamicin does might be helpful in inducing more inflammation and then reducing the outflow through the BLEB. Does that answer it?
Yes. Great.
I can remind you in medical school, when we remember the pneumothorax, the spontaneous pneumothorax, where they sometimes they inject, I think it's tetracycline, they inject it between the pleural cavity and the lung to induce inflammation, and then the lung, when the lung expand, it will attach to the pleural cavity, and then no more human pneumothorax will occur. So this is like similar principle.
Yeah, but this is a property of gentamicin or for every aminoglycoside?
Gentamicin more than the other aminoglycosides. Yes.
Okay.
Yeah. So in the like gentamicin has been is not as common as it used to be in the past. So if I don't get access to it, I might use tobramycin instead.
Thank you, Doctor.
You're welcome. Okay, so we agreed that if we have an early post-op complication with a high intraocular pressure and deep AC, deep chamber, so we have either internal blockage or a tight flap or external blockage. If we have internal blockage, you can identify it with gonio because you're going to see through the gonio, and you will see a blockage happening somewhere there. It could be iris, it could be blood, it could be uvea, it could be vitreous tag. Management options: if it is a fibrin or a blood clot, you can use TPA. Intracameral TPA works very well and works even within hours. You see the patient and the pressure will be down and everything looks good. Steroid or revision if it is something, let's say, if it is a vitreous that you cannot get rid of, you might have to go in and do anterior vitrectomy. And then tight flap. Tight flap, if it is within 48 hours, digital massage after 48 hours, you can do it. Suture lysis. Suture lysis you can use using argon laser with a very small size, spot size. But keep in mind, the suture lysis is always something you can do if it is within 1 to 4 weeks. Usually past 4 weeks, the adhesion will be severe that even if you do suture lysis is not beneficial. So if you want to do it and get the benefit of it, you may want to do it within this window. And then external blockage. The blockage can be external, somewhere there. That could be a blood or fibrin. It could be early encapsulation. And if that's the case, we will talk about encapsulation in the next few slides. Okay, now back to the early high pressure flat anterior chamber. So what could this be? It could be pupillary block, right? Could be suprachoroidal hemorrhage, or it could be malignant glaucoma. If it is pupillary block, first of all, rule out by looking at if there's any surgical PI. If there is a surgical PI and it's open, then that will rule out pupillary block. If there is no surgical PI in that patient, the management will be laser PI. You can do with laser PI, and that's it, done. Suprachoroidal hemorrhage, as we said, you can have it anytime in the post-operative stage, but most commonly in 1 to 3 days. Dark choroidal swelling. Usually, when you look with the fundus exam, you will see a peripheral dark, choroidals versus the choroidal effusion. Choroidal effusion are lighter in color because they have no blood. They just have effusion in them. But the choroidal hemorrhage is usually dark because it has blood, and the blood is stagnant, so it will take that dark color. Typical symptoms for suprachoroidal hemorrhage is that they get pain and nausea or vomiting. It's severe, like patients sometimes scream from pain. It's very, very painful. Versus effusion is not very painful, sometimes asymptomatic, but they can have a mild pain. And then diagnosis, you can make a diagnosis either by indirect ophthalmoscope or B-scan. Management, you may observe if it is just peripheral, make sure the pressure is okay and no central touch. And they can be drained in 10 to 14 days if they are not resolved. But also you want to discuss it with retina service and go from there. Malignant glaucoma is another possibility. The other name is aqueous misdirection syndrome. You will see a diffusely flat AC. And interestingly, malignant glaucoma, even though it's called malignant glaucoma, but you can have either a high pressure or even a normal pressure, and sometimes even a low pressure can still be malignant glaucoma. So it's something that you have to keep in mind and always be thinking about when you have a flat AC. So diffusely flat AC, use cycloplegia, because 50% of the time you can resolve it just with cycloplegia and aqueous suppressants. YAG, anterior vitreous face disruption, can also be, or hyaloidectomy can be used, but it's variant, in the success rate, because you can break that interface and get that pocket of fluid out. but the definitive treatment is pars plana vitrectomy. And when I say pars plana vitrectomy, and retina colleagues know that, you gotta do a very, very good pars plana vitrectomy, like a complete vitrectomy. Sometimes if they go for vitrectomy and they have recurrent malignant glaucoma, then you know that they haven't done a complete vitrectomy. So ensure that you talk to the retina person and tell them, please ensure that you do a full vitrectomy, not just a core vitrectomy. Okay, now we're going to talk about the late complications with any intraocular pressure, low or high. First, with any intraocular pressure, you can have cataract. Of course, surgical management will be, or you can have this aesthetic BLEB. This aesthetic BLEB, even though it's rare, but it's something that really annoying to the patient, and it's very hard to treat. Even though the pressure will be, the BLEB will look beautiful and the pressure is like in the low teens or in single digits, and you're happy with the results, but the patient is not. The patient will tell you, I regret doing the surgery because of this. They feel their eye all the time. And how to deal with it? As I said, it's a very difficult, complication to deal with, but you can try lubricants, non-steroidal anti-inflammatory, autologous blood injection to induce more, less, to reduce the BLEB size, compression sutures to reduce the BLEB size as well. You can try a pressure patch, or eyelid riding high. Sometimes the eyelid is riding high above the BLEB. In this case, you can use or consider gold weight to the upper lid or lid recession procedure. But if all these fail, then a revision and BLEB minimizing conjunctivoplasty procedure can be considered. And last resort, this would be a last resort, and you try to avoid doing it because most of the time it's not successful. And then late, you can have infection as well. Infection can be either blebitis or endophthalmitis. Here's another stimulating question. The major feature that distinguishes blebitis from endophthalmitis is appearance of the BLEB, degree of conjunctival discharge, degree of pain, AC inflammatory reaction, or presence of vitritis.
Most answers are E.
That is correct. Okay. Yeah, so again, I agree with that. So main differences between blebitis and endophthalmitis. Pain, you can have some pain with blebitis, but more so with endophthalmitis. Vision, usually normal in blebitis. In endophthalmitis, of course, it's reduced. AC reaction, you may have 0 to +1 cells, but in endophthalmitis, you're going to have a lot of cells and then also hypopyon. Vitritis, vitreous reaction, you never have in blebitis, but in endophthalmitis is the hallmark. So blebitis, it's a precursor of endophthalmitis. It can convert into that at any time. Milky BLEB, they call it. You see a BLEB as if there's milk in it. AC reaction, you can or cannot have. It can be either way. But if the cells are more than 1 to 2 plus cells, always keep endophthalmitis in your mind. Vision near normal. Treat aggressively with topical fortified antibiotic. Systemic antibiotic can be considered, and very close follow-up. And educate the patient if they have any sudden decrease in vision or starting to have increasing pain. have them come back quickly and looked after. Endophthalmitis, it's different group from EVS, endophthalmitis vitrectomy study. Vitreous tap and intravitreal antibiotic is considered. Pars plana vitrectomy if visual acuity is less than hand motion. AC tap and culture if appropriate. Use fortified topical antibiotic and consider IV or at least peroral gatifloxacin and cycloplegia. Late post-op, any IOP also can be something called corneal dissecting or overhanging BLEB. I don't know how they still pop in, when the mitomycin C was used with higher concentrations in the old days, we see these sometimes pop in our practice. You've probably seen them, Dr. Mazen. You see those overhanging blebs where we have a bleb that grow over the cornea. It's like having a pterygium that just grow over the cornea.
Yeah, I've seen some, but not to this extent. This is a huge.
Yeah, so this is huge. So if you look at this, this is a cystic bleb that just continued to proliferate and advance over the cornea to cover the visual axis. So if you have that, what you do for this, you basically surgical dissect. And interestingly, when you surgically dissect these, they don't leak. It's like a sponge. You cut it and you don't see leak. Most of the time you don't see leak, but be prepared to do a conjunctival advancement flap if there is a leak. But sometimes these you can even trim at the office base, like it doesn't have to be in the OR all the time. But it is preferred to be done in the OR and then in the operating room, and you just shave this off the corneal surface and then be ready to advance a fresh conjunctiva from above to cover to the limbal area. Sometimes to advance conjunctiva in a patient like this, you might have to do a superior fornix relaxing incision in the upper fornix to advance some conjunctival fresh tissue to the front. Okay, so we're late. And then late and low IOP. It can be overfiltering bleb, even late. So what you get from that, you get hypotony maculopathy. Risk factors for these male patients, young, high myopic. Best treatment is prevention. So well sutured flap, close follow-up, careful use of antimetabolites. Sometimes you in a young myopic male, you may want to avoid the use of antimetabolites or use a very low dose and very short exposure time just to avoid hypotenuse maculopathy. So if you have a low blood, what you do, autologous blood injection can be used, laser grid treatment to induce some inflammation in the bleb area. Compression suture like corneal or incorporated bleb. You can go over the conjunctiva and just close the flap tight. Gold weight. Surgical revision is also possible. And then remember, cataract formation more common in these settings. And then high IOP and late complication, it can be, again, remember we applied these in the beginning. You can have these late as well. They can happen anytime. So if they are late, identify with gonio the same way and treat as needed. If it is around here, like in the internal blockage in the internal os, or if it is outside, like on the tight around the flap, you can do a massage. A massage usually works within the first 3 to 4 weeks. 1 to 4 weeks. After that, it's very hard to do a digital massage. delayed suture lysis, and then BLEB needling with 5-FU and mitomycin C can be done when it is past 4 weeks. You can do that. And also depends on the patient's aggressiveness of healing. You know, if you have a person with, let's say, a history of keloid and they scar down quickly and they have multiple surgeries before, and you know this is a setup for excessive scarring, you can start needling early on and injecting 5-FU or mitomycin C even. BLEB encapsulation, it's usually a 10-ounce capsule that goes around the BLEB and just encapsulated or form around it to prevent any further diffusion of the aqueous humor. And also you can have a conjunctival scarring, just a flat BLEB that there's no flow at all. You may need to, you can either needle or may reoperate. So 10-ounce capsule or encapsulation, treat IOP first. And you can allow 3 months for spontaneous resolution. But if after 3 months it doesn't resolve, then it's likely not going to resolve. Be more aggressive with your management. Try needling. It works only 50% of the time. Surgical excision also can be considered. Consider 5-FU or resection with needling. Okay, and then needling you can do with a 27 gauge needle, where you pass it away from the BLEB edge, and you go in. Try to have the bevel of the needling facing you so you can see it all the time, and you go under the capsule and try to dissect it and cut it in different directions. If you can go under the flap and lift it up and try to see while you're doing it, try to watch the BLEB form. That means the aqueous is moving from the AC to the BLEB area. Again, just a reminder, post-op complications, we have early, we have late, any IOP, low IOP, high IOP, and same for the late. For the any IOP, we have hyphema, we have uveitis, we have Dellen. Early and low IOP, we have flat BLEB or formed BLEB. High IOP, we have flat AC or deep AC. For the late ones, we have cataract, infection, or uncomfortable BLEB or dysesthetic BLEB. For late complications, we have overfiltering or leak. For high IOP, it's either a tight flap, internal blockage, or external blockage. So in this picture here, I put, I don't know if you want to know what it means. I mean, keep everything in mind. You know, all the ideas, keep them in mind. But don't lose your smile, and always remember your coffee, okay, when you're dealing with glaucoma surgery complications. Thank you.
Thank you very much, Dr. Gdih, for this comprehensive overview. And it was very informative, very simple, systematic. Now we see the questions. How can we manage post-glaucoma drainage device diplopia?
Okay, good question. Well, I assume if you say diplopia post-drainage device, you're talking about post-tubes, because it happens post-tubes. And more so with the Berveld tube than with Ahmed tube, because the Berveld has wings that goes under the muscles and can affect the muscle function. So I think is like a prevention would be the good way, is that you identify the muscle when you're hooking the muscle. Try to be mindful of the muscle and not to rip, tendons and make sure the muscle, the tube is like the tube wings are going underneath the muscle, not into the muscle bundles. Like sometimes inadvertently, if you hook in between the muscle fibers, you can enter the wing into the muscle fibers and affect the muscle function. And yeah, overall, with Ahmed valve, it is much less to see that, but more so with the bare valve, the tube. If it happens, I mean, I have never had to go back and fix a muscle like that, but I assume if it is severe, you can go back and see where the tube is and try to fix it, or else talk to some strabismologists to help with that.
Great. How to treat encapsulated Ahmed glaucoma valve?
Encapsulated Ahmed valves are, there is a phase in after Ahmed valve. It's called the hyperencapsulation phase, which happens typically after a month from the procedure, where you can have a very thick capsule, almost like leather, and you have this big cyst. What I have done with them in the past, that you can start with aqueous suppressants, especially Diamox. You can put them on topical aqueous suppressants, some steroid, and I mean, 50% of the time you will succeed medically. If they continue to happen despite the treatment and the pressure is very high, you can always puncture the capsule and then have the fluid out there. They're going to have hypotony in a day or two after that, and it's going to fill again and does the same thing. But having multiple visits and multiple punctures while keeping the aqueous suppressants and the anti-inflammatory, sometimes they collapse and you don't have to go back to the OR. If all that fail, then you can take them to the OR and just dissect that capsule and remove it.
Great. Now you showed us the picture of the large dissecting BLEB. Mm-hmm. Okay.
Yes.
Is there any? Are there any predisposing factors such as the application of mitomycin C, time, concentration?
Yes. Yeah. So the dysaesthetic BLEBs are unfortunately a late complication. So it's hard to relate why they happen, but they do happen in BLEBs that tend to be diffuse and occupying a large area, and mitomycin C is known to allow the BLEB to work more, and if you see a larger BLEB, it's likely that mitomycin C was used. So I would say yes, the conscious use of mitomycin C would be appreciated, but again, sometimes they don't appear right away. They appear several months after, and the patient comes to you and say, I have something in my eye. I'm always aware of my eye. They tell you this area is, even on a touch, when you touch it, they just jump. They feel like it's hyperesthetic. And if you touch it, they feel that pain. It's very not well understood, the mechanism, but it is associated with large BLEBs, and reducing the BLEB or trying to reduce the filtration area has been helpful.
Thank you. What is TPA?
TPA is a tissue plasminogen activator, which is used in it's a medicine used in you can say busting a blood clot, when people have acute, I'm not sure if they use it in stroke or somewhere, cardiology, they use this TPA to bust a blood clot. So when you put it inside the anterior chamber, that's what it does. It just dissolves any blood clot, and it dissolves any fibrin. And I commonly use it in after tubes, when you get the tube blocked by a blood clot and the pressure is not coming down, it's not clearing. You just put 0.1 cc of that into the anterior chamber, and you have the patient wait in the waiting area for an hour or two, and then you check the pressure. They're all good, and the flow is good through the tube, and it's all good. It's very, very good medication. I like it.
Thank you. Do you have experience with surgical management of cyclodialysis cleft?
No, I have never had to correct one. Luckily, all the cyclodialysis clefts that I had in my practice dissolved or resolved medically by just with aqueous suppressants and waiting, and it just by observation they went away. But yeah, you got to keep that in mind. And typically the patients will come to you with hypotony, and you look at them and check everything looks good, but they have hypotony. And then sometimes all of a sudden they come to you, they will phone your office and say, hey, we have eye pain and something is not wrong, something changed drastically. And you have seen them, let's say, for the last several weeks, and every time they come in, their pressure will be 3 or 4, and when they come that day, their pressure is 40. So when you look, that what happened is that spontaneous closure of that, because you have them on all these, you have them on no aqueous suppressants, you have them on no anti-glaucoma medication, and they come in with a sudden rise of pressure. That means it's a cyclo. That sometimes can be diagnostic. They come in and you see that pressure rise suddenly, or then you scratch your head and say, hey, what I was dealing with was a cyclodialysis cleft that have just closed. And then again, you put them on anti-glaucoma medicine, and sometimes they will open again. And when they open again, their pressure drop down to 0. Sometimes it can play tags with you, this cyclodialysis cleft. But if it keeps on playing tags with you, that you put them on anti-glaucoma therapy, they go down to 0, and then you stop them, they go up again, then you need to do some surgical intervention.
Dr. Gdih, can I just add something very quick, please?
Yeah. Yes,
I have very modest experience in the cyclodialysis cleft, so I have something like a very kind of simple plan in these cases. Usually, if the cyclodialysis cleft is anything between 3 to 4 clock hours, which you can either visibly see it directly with the gonio or with the UBM, as you kindly mentioned. So that's usually resolved by its own with the medical treatment, with the conservative treatment, and that's include, mainly the dilating drops like atropine, possibly waiting, anti-inflammatory steroid drops. If this is more than 3 to 4 clock hours, so there are 2 options. You can either consider cyclodiode laser. You do 2 rows in the area, like you do usually, but not only 1 row, 2 rows in the sector. The other option will be to try argon laser trabeculoplasty, but aim for the deep tissue inside the cyclodialysis cleft to include or induce the inflammation. And obviously, if this is more than that, so here you need to aim for the surgical repair. And with the surgical repair, you need to expose the sclera and stitch the whole thing. But in these cases, you need to be prepared for a very high spike in the pressure after repairing this, which could be always a big problem. So those patients will need to be followed up very closely after that. The other thing, I meant just to ask a couple of questions, really. From your experience, do you usually follow any special measures while operating, like doing TRAV for patients who are highly myopic?
Mm-hmm. Yeah, I always try to, in highly myopic patients, that what I try to do is use 0.0 0.2% of mitomycin C, not more than that, and not to exceed not to exceed 2 minutes of exposure. And also the closure, that I make sure that I have a tight flap down, and try to do my flap a little longer to have a posterior, more posterior flow, like have a longer way for the aqueous to travel under the flap. Yeah, those are the measures, and I do leave Helon GV in the AC just to extend there, and then I deal with the pressure as needed. As I said, I think the most important favor for you to do is to leave that side port. If you have a high pressure, you can always burp the wound, and then you can get lower pressure. But if you and also use that to inject some if you need. So leaving an access is a good idea. But definitely those will be kept in mind. I still use mitomycin C on them.
Yeah, how much do you usually inject of GV inside the AC? 0.1 or more?
You know, I just leave some that will go. It can be even 0.1 cc is enough.
Mm-hmm.
I just because it will go up to the against the ostium, and then delay the flow. That's the idea of having it.
Yes, yes. And last question, for the hypotony, how long do you usually wait to do something? Like some people, they wait for a few days, some people wait for few weeks, or even up to 3 months. I mean, if you have a shallow choroid in addition to this irregular macular indulation without CMO or anything like this, would you wait for a few weeks or more or less?
Yeah, it really depends on what the reason is. Let's say they have an overfiltering BLEB, then
overfiltering BLEB.
Yeah, I mean, if they have an active leak, and that's why they're hypotenuse, then obviously I need to fix that leak. So probably the wait time is not that long, or put an over bandaged contact lens. But if the hypotony is due to overfiltration, let's say, because everyone is dealt with differently. If it is overfiltration, I definitely tend to wait, and I don't need to go suture, because what I'm going to face in the near future is that their natural healing response, which is the biggest enemy for any filtration procedure. You know, our biggest enemy is healing, you know, in all glaucoma procedures. If we can find that healing solution, then we find the solution for glaucoma. Yeah, I tend to wait more than intervention. I rarely intervene for a hypotony. I mostly wait and use conservative measures, like filling the AC with Helon, or putting a bandage contact lens and close follow-up. I like to do that.
Okay, good. Thank you.
You're welcome.
Now, have you seen, the question is for both of you, Dr. Gdih and Dr. Munir, have you seen a case of non-resolving choroidal hemorrhage and normal IOP?
You could. Yeah, you could still have like a small choroidal hemorrhage with you know, normal to slightly high pressure. Yes.
So in this case, just observation or any intervention for that?
Yeah, observation is possible. You know, it's probably going to take some time, but it is possible that it will resolve.
Okay. Now,
yeah. It's in a tight area. You know, it's if it is not in that in the short ciliary nerves area, where it has this shearing forces effect that the patient will be very uncomfortable, then yes, you can wait on it. And of course, look at systemic things. If they are on blood thinners, you may want to consider stopping them and monitoring their INR level. If it is too high, need to be reduced. And yeah, like dealing with any other bleeding.
Okay. Yeah. Blood pressure, for example, has a role in this?
Yes, it does.
Blood hypertension?
Yes.
Okay.
Controlling blood pressure is a key for this. Yes.
Great. Now, when we were residents, we learned to give subconjunctival injections, a combination of steroids and some atropine. Is there any role for such a procedure in the treatment nowadays? Subconj injections?
Yeah, there is. There is. You know, sometimes like if I'm dealing with an inflammatory process and that's causing hypotony, for example, choroidal effusion, that would be a good example. I sometimes, even if especially if I question the patient's compliance with therapy, I might put a depot of Kenalog under the conjunctiva and leave it not under tenons, under conjunctiva. So in case they go into high pressure spike, I can easily dissect that and remove it if I need to. But yes, yeah, still has a role. Yeah.
Okay, great. Somebody is asking, after trabeculectomy, scleral flap was leaking at the corneoscleral junction because it was torn during surgery after suturing. So there was continuous leakage. What to do?
That's during the surgery, I assume.
During the surgery, there was a tear, maybe wasn't managed properly, and there was a leakage after the operation. So how to treat this?
Yeah, again, same thing. You can treat it as a, as an early stage where, your wounds are not closed tight, and you can, continue to fill the AC with Helon or watch them for shallowing. Anti-inflammatory, gentamicin to induce some inflammation, and then just wait it out until, as long as we don't have a corneal lenticular touch, or we don't have a completely flat AC, we can always observe, and see how the changes are. Or if we don't have a very high pressure that need immediate management. Otherwise, the trabeculectomy, usually it makes its way, and we just need to direct it. Sometimes we need to, if the aqueous is not going to the under the conjunctiva, we need to look why this is not happening. Is it due to blockage of blood? If it is, then maybe anti-inflammatory will help. If there is a leak, it will likely close on its own. You just need to wait for the healing process. But you wait as long as it is safe to wait. If it is not safe to wait, then you do want to intervene and suture or.
Okay, great. Do you prefer to leave Helon in the AC at the end of the surgery in the case of high risk of choroidal infusion, like in Sturge-Weber syndrome, for example, or myopic patients?
Yeah, definitely. Yeah. Yeah, I always do in tube implants. I always leave Helon, even if I ligate and do everything. I always leave Helon, but I always leave like a temporal side port. It is, I learned over the years that, dealing with hypotony is like 10 times more difficult than dealing with a high pressure post-op. So I always leave Helon in tubes. In traps, it depends. If it is a high risk of hypotony, I do leave.
Great. Some advocate an inferior side port at 6 o'clock for the management of any eventual post-op hyphema. What's your opinion?
I never done it, and I would be concerned about inferior side port just because of the risk of infection. That area is stagnant and it can collect, tear debris, whatever, you know, in that area. And if that sneaks into the AC, then you're looking for infection. So I would be hesitant to do that.
Mm-hmm. How to use plasma intra-BLEB to manage overfiltration?
Sorry, plasma? Plasma what?
Plasma intra-BLEB, to inject plasma.
Mm-hmm.
This is the question, like this: plasma intra-BLEB, to inject maybe
yeah, the autologous.
Yeah, autologous, yes, exactly, intra-BLEB to manage overfiltration.
Oh, I see. Yeah, that would be similar to autologous blood injection. Yeah, you just go, as when you do needling, you go in and just inject blood into that area to reduce or induce inflammation and reduce the BLEB size. It will be similar to what with the 27 gauge needle, that you go from 2 to 3 millimeter away from the limbus, from the edge of the flap, and then subconjunctivally watching the needle bevel, and then inject around that area.
Okay, great. Now, what if, yes, Dr. Munir, please.
Yeah, obviously I had some experience with this autologous, but I'm not sure if it's okay to share with you. For me, it didn't work. I tried a couple of patients, possibly. It depends on the severity of the hypotony. In my mind, I have very straightforward approach in these cases. If the hypotony is really bad and early, so like, let's say, severe hypotony with the shallow AC, overfiltrating BLEB, in addition to choroidal detachment, and definitely early maculopathy, I don't like to wait, because as Dr. Gdih said, it's always hypotony can blind within weeks, but high pressure can blind within years. So in these cases, even if you, let's say, wait, sometimes you wait for 3, 4, 5, 6 weeks, and then you end up after fixing it with the epiretinal membrane, which will last forever and cause significant deterioration of the vision. So in these cases, I think it's always better to not faff around, just go ahead and fix it. And what I found is, just if you put 3 or 4 stitches, like transconjunctival stitches, like compression stitches over the BLEB, even without exposing everything, you can try it. It takes 5 to 10 minutes to do. You can do it under topical. You just need to do it in the theater, obviously. But that works much better than injecting or even applying contact lens or patch or anything like this. But again, it depends on how severe is the hypotony. I think there is a very nice paper. It's the Moorfield's Safe Technique, which is excellent paper, actually. It's like one of the best papers about how to do the trap and reduce the risk of hypotony. The key here in these cases is mostly making a small opening in the sclera, not large one. You need to have thick flap, because thin flap is a big risk of hypotony. And for patients who are very short-sighted, myopic patients, you need to have no flow whatsoever on the table, even if that's meaning applying 5 releasable sutures. You do as much as it takes. And the last thing, you need to do a very posterior dissection of the conj. So go as far as possible and apply the mitomycin as far as possible, not on top of the scleral flap. These tips can really significantly give you much better results and reduce the risk of hypotony in these cases.
Very nice input, Dr. Munir. Thank you very much.
Dr. Mazen, let me please answer this. Thank you, Dr. Munir. That was very helpful. Someone asked a question here, which is very good. I like that, because this is something I didn't mention. It says from Rami Khadr, what would be the best management for late 2 years, post-trap hypotony with IOP, maculopathy, hypotony maculopathy, deep AC, poorly formed BLEB, No leak, no choroidals, quiet eye. Possibly ciliary body shutdown. Yes, so ciliary body shutdown can be prolonged. And even though you look for leak, you don't find any leak. You check for cleft, you don't find a cleft. And everything looks okay, except that they're not making enough aqueous. So what to do? In rare situations, you might have to have someone who's very good at reading UBM and get a good UBM and see if there's any inflammatory membrane encircling the ciliary body. Sometimes these patients will need a pars plana vitrectomy and membrane peel of the ciliary body band, where that membrane has to be dissected and removed in order for the ciliary body to go back and produce fluid. Yeah, it's a very unfortunate thing, but sometimes they have to do that that way. Yeah, there is no other way. Yeah, because those are fibrosed. You know, that membrane is just covering the, and eventually what they result in, if they don't intervene and remove that membrane, they may end up with a ciliary body detachment.
Okay, great, Dr. Gdih. Now somebody is asking Dr. Munir to share the Moorfields study, the link for the Moorfields study.
Yes, sure, I will.
How to share it with the audience, Dr. Munir?
Shall I send it now to the chat?
Yes, if you don't mind, please.
Yeah.
Meanwhile, Dr. Gdih, is there still any question you would like to answer?
I'm trying to skim through them, see.
Because we still have 4 minutes, so maybe to answer 2 questions.
Someone said, what is the picture, Muhammad Abu Marzouk? What is the picture of BLEB you like to see first day post-op, week 1 and 1 month? Well, the BLEB day 1, I would like to see it, diffuse, less vascular, no blood, and have microcystic edema on the conjunctiva. You know, there is I don't know if you're familiar with the Indiana classification of BLEBs. It's available on Google. Just look up the Indiana classification of BLEBs. What it does, it describes the appearance of the BLEB, and you can monitor it. You know, having a microcystic edema on the conjunctiva overlying the BLEB is an indication of filtration. So if you see it, it's a good sign. If you don't see it, that means the BLEB is not filtering as well as it should be. And you don't want to see a thick wall BLEB, because that's a sign of encapsulation. And obviously a diffuse, you know, not too low and not too high, like just moderately elevated BLEB, and limited, not widely expanded. That would be the ideal BLEB that you look for. And it would be the same, you know, at 1 week and 1 month, except the 1 day you're probably going to see some blood there because you just have done the surgery. But that Indiana classification is helpful in monitoring BLEBs. You know, whenever you mark down what the rates are, in terms of Indiana classification talks about the appearance, like the cystic appearance, the blood vessels, the extension, how many clock hours, and also the elevation, the height of the BLEB.
Perfect. Thank you very much, Dr. Gdih. It was very nice presentation, and I'd like to thank Dr. Munir, of course, for the discussion. I'd like to thank everybody for being with us, and hope to see you all next Sunday with Dr. Munir. This time, he is going to talk about the mysterious optic nerve or optic disc, let's say. same time, and but next Sunday. And of course, Dr. Gdih, inshallah, will be with us because you will enrich, of course, the discussion. And thank you very much for all of you, and good night.
Inshallah.
Thank you very much. Excellent.
Thank you.
Thank you.
Thank you very much, Dr. Sanjab, Dr. Munir. I appreciate the opportunity, and I look forward to more fun, inshallah.
Inshallah. Jazakumullah khairan. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.